Hello, this is Dr. Dheeraj Masako. I'm a consultant anesthesiologist, and so today I would like to answer a question that you guys are asking: can anesthetists see OPD? And I would like to answer that question. Basically, as an anesthetist, you can see an OPD. See, any person who finished their MBBS according to NMC can see an OPD. So, if you're really wanting to see an OPD, then you're eligible to see with your MBBS degree. Nobody is going to stop you, but your skills are required in somewhere else. Your skills are required in the operating room to deal the crisis and to anesthetize patients and in intensive cares after doing certain fellowships or degrees. But seeing a patient is a different feeling. I can understand, and even I miss seeing patients in OPD because after a certain age, you really want to interact with people and you really want people to appreciate you. I can understand that, but that's what you're going to miss in anesthesia. That is the price you have to pay to become an anesthesiologist. So, but there is one way only if you really want to have an OPD with anesthesia, that is by doing pain medicine. So, pain, how to do pain and what fellowships to do and everything we have discussed in detail by Dr. Roshan in my channel. You can go through that channel in detail. We're not going to cover all those things now, but today Dr. Roshan is there with us. He is going to tell us what kind of OPD services will be run in pain, and when you sit in OPD, what kind of patients usually come, and what treatments usually will be done commonly, and what kind of procedures he would advise. So, welcome to the channel, Dr. Roshan.
Thank you. It's good to be back again here. Like Dheeraj already said, I understand why you guys want to see patients because you do miss the patient interaction, and even then, if you want to see the OPD, you can still do it. But always know, like as an anesthetist, your requirement is somewhere else. Now, coming to my pain OPDs or generally in pain OPDs in India, depending on where you are, I think majority of the patients you will see is still myofascial pain. So you're going to have a lot of neck, upper back pain, neck pain. You'll have a lot of headaches. You'll have low back pain, etc., which invariably turns out to be muscle in nature, muscular in nature, myofascial, as we say, a lot of trigger points, etc. So that we generally discuss. We do an examination, thorough examination, take a detailed history, etc. On any given point of time, any OPD with a pain patient typically takes about 45 minutes, maximum up to an hour at least. So in that way, your OPDs with a pain patient is different from other specialty OPDs, which usually gets only 5 minutes because all investigations, it's very straightforward. Whereas pain management, these are the patients who have seen other specialties. More often than not, they are referrals from other specialties, so they already have all the investigations and they tried operations and the pain has still not gone away. So that's where you come to the mechanism of pain. You have peripheral sensitization, you have central sensitization, a lot of anxiety, depression, sleep deprivation, fearfulness, kinesiophobia, fear of movement, loss of functionality, and a lot of social components. This has affected their family life, the job, they're losing their finances. So you have such intense baggages when the patient comes in. That's why you take 45 minutes. Detailed history. We also do assessment for the anxiety scores, the depression scores. There's a lot of assessment which happens, and you have to build the rapport with the patient. So finally, when you come up to a management plan, most important time I spend my time is patient education. I educate the patient on the pain mechanisms, why they have pain, if every investigation is normal, etc. So I'll make sure I spend a lot of time educating the patient, because once a patient becomes educated, once they understand why they are in pain, that's half the battle won. Then we come to medications. I'll also prescribe a bit of medications. Your neuropathic medications, your pregabalins, gabapentins, amitriptyline, duloxetine. You have paracetamols, you have NSAIDs, opioids, Ultracet. Not so much opioids, but you tend to multimodal management of pain.
One question I would like to interrupt you, but in OPD practice, can they give opioids? Is many people have this doubt.
So it depends on your practice, really. Since I work in a multi-specialty tertiary center hospital, we have access to opioids.
Okay.
But Ultracet, tramadol, you should be able to get in any pharmacy. So that's the maximum. You don't go in opioids anyway.
Yes.
In chronic pain, you do not want to give them morphine and fentanyl patches and send them home. That's not pain management. You want your ideal goal in the end of the day for your pain patient should never be to decrease the pain. I know it sounds funny. What we focus in pain management is to improve the quality of life and functionality. So if your overall quality of life improves, overall functionality, the patient, we always ask the patient, what have you lost because of the pain? So patients can say, I've stopped playing my favorite sport. I start going out with my friends, traveling. I can't pick my grandkid up, my son up. So I'll say, okay, let's focus on getting those things back. And so we focus on those goals. So when you achieve those goals, automatically your pain also comes down. So it's not about you giving injection, pain goes away, and patient is fine. So in OPD, lots of time spent on patient education, little bit of time on prescribing the medication. Then we go over the physiotherapy. That's a big component of pain management. Physiotherapy, rehabilitation, prehabilitation, etc. So there's a lot of things that physiotherapists do in a pain management setup. They use ultrasound therapy, IFT, acupuncture, dry needling techniques, just stretches, the exercises, core strengthening. For pelvic floor pain, there's a lot of biofeedback stuff which is happening. So we talk about rehabilitation. Then you also talk about psychology of pain. So if the patient has severe anxiety, stress, and depression, etc., I refer the patient to a pain psychologist. A pain psychologist is very, very in tuned to chronic pain, and they sort of give the two main therapies such as cognitive behavior therapy, acceptance commitment therapy. So they really give them some psychological inputs, how to do mindfulness technique, relaxation technique, distraction technique. So that's very important. So we talk about the psychology option, and last is injection. Because when a pain novice, when they're starting, you only know about injection. That's all you want to do. But I'm always putting injection last. And I always tell my patient injection is last. Why is there injection there? Injection is there so the pain can decrease, so that he can do the remaining things, so that he can go for psychological therapy, so that he can undergo physiotherapy sessions. So when the injection effect wears off, now injection effect, yes, it's there. Patient is comfortable for 6 months, say even up to a year. But after that, pain will come back. Understand, we're not treating the condition. We're just numbing the nerves wherever it is, right? And that's what pain management is. Literally, it says pain management. We are not pain curists. The word is there. It's called pain management. The International Society for Pain is known as International Association for the Study of Pain. Indian Society is called Indian Society for the Study of Pain. We're not Indian Society for curing pain. We're still studying. The word study is there. So still a lot more knowledge is coming. So pain management, literally, so injection is the last option. But yes, it's a very important part of it. But tell the patient why you're giving this injection. If you feel patient can still do the other things without injection, please go ahead. But if the patient is such severe pain, yes, okay, I need to give epidural steroid now, or some injection shoulders, or injections would be for cervical epidural, cervical facet, shoulders, you have intra-articular joints, subacromion for spinatus syndromes, you have lumbar epidurals, transforaminal epidurals, facet joints, radio frequencies, SI joints, hip joint injections, intra-articular knee joint, genicular nerve blocks for the knee, ankle joint injection. These are the basic injections, and a lot of trigger point injections, and sympathetic pain, you can have sympatholytic blocks, etc. So those are the things, but I would say injection forms the last part. So discussing all these things in an OPD takes me 45 minutes to an hour. Ideally, you should do that also, because a huge component of pain is also placebo. Just by you spending 45 minutes with the patient discussing all these things, a huge component of pain does come down. So you'll be surprised when the patient leaves the clinic, they actually already feel a lot better, that someone's listened to them after so many years and someone's trying to do something to improve their life. So it takes a lot out of you also, because 45 minutes to an hour. So in one day, I will not see more than 6 patients.
Got it. You can't see some 30-40 people.
That's not, no.
It's like a general physician opening.
No. For a primary new patient, 45 minutes to an hour. But if it's a follow patient, then it's easy. Follow patients, 5-10 minutes.
Got it. Superb. So you will see the patient in OPD, and if you have to do a procedure, then you will take him.
So yes, ideally you should schedule it for some other day if you can, because you still have to take some precautions, sometimes fasting guidelines, and sometimes patients also need to discuss their financial bits also.
Got it.
But most of them, if the patient wants to do injection that itself, you can, because most of them are OPD based, ultrasound guided blocks, or just a C-arm guided blocks. You don't have to worry so much, but of course, if you're doing lumbar epidurals, etc., if they're on blood thinners, your ASTRA guidelines need to be followed.
Correct.
That's only a way. Otherwise, most of them can be done the same day also if they're willing. Another thing is, if you're doing injection, make sure they've come with somebody.
Yeah.
Because you need some attenders in case something goes wrong. You can't. Some epidurals, there's weakness of the legs, they can't go home. Even then, for 24 hours, they need to be with somebody. So make sure there's someone at home also.
Got it.
These are a few things.
So that's it, guys. If you want to set up an OPD, this is the only way I feel. But there are some intensivists who also run their OPDs, and I know a few of them. But those are not real OPDs. There are something called as follow-up OPDs. So, for example, I'm a neurointensivist, and if I treat some head injury patient, if he's going home and then he comes back, I'll understand his physiology better. So that kind of OPD, that's a follow-up OPD. But the real OPD is what pain specialist does. So this is the only way anesthetist can run an OPD. But if you tell, according to an MC, any person with MBBS degree can run an OPD. So in that way, anesthetist can have an OPD, but doesn't make sense, I feel, because your skills are required in somewhere else. And if you're really a OPD kind of person, then don't come into anesthesia. But if you come, this is one way of doing. That's what I'm trying to tell. Hope you guys like this video, and thank you very much. So see you. Thank you, Roshan, for your updates. And
Yeah, thank you. I'm happy to be back, and
Yeah.
cheers to Dheeraj, Masapu, and
yeah,
all the best.
my subscribers know you actually. You're there in so many videos.
Yes,
So-
I'm a Masapite fan also. So, guys, spread the word. Let's make it 10,000 subscribers.
Yeah, we
very
crossed
soon.
5,000. Yeah. So
We
thank you
crossed
guys.
5,000,
Yeah,
yeah.
we crossed 5,000, and now I think we are we're going to touch 10K in some. I don't know whatever time we'll be touching. We are not in a hurry, so we'll go around. Okay. See you, Roshan. Bye bye. As usual, Dr. Dheeraj Matsapur logging off. Roger that.